Hi, everybody. Welcome back to the Get Healthy Tampa Bay podcast. Today, we have an awesome guest, Dr. Kerry Sueldo. Welcome to the podcast. Why don't you tell everybody who you are and what you do?
Dr. Reller, thank you so much for having me here today. For those who don't know me, as she said, my name is Kerry Sueldo. I am double board certified in both OBGYN and REI. REI is a very short acronym for a very long name, reproductive endocrinology and infertility, but I'm more commonly known as a fertility specialist. And so I'm typically the one that patients will see once they've been trying for a while and things just aren't happening. I did my OB-GYN residency training out in California at UCSF Fresno. I actually got the Resident of the Year award as nominated by across all residency programs. I then did my fellowship at the University of Connecticut. So I spent 3 years in the Northeast, and I actually got my master's in clinical and translational research during that time. My first position out of training was at a big practice in South Florida. So I was in Miami for 3 years. That was a lot of fun being a young single professional. And then I met my husband after Hurricane Irma in 2017. And we eventually got together, got married, moved out to California, had 2 babies, and then just recently moved back here to the South Florida coast. So I'm currently residing in Fort Lauderdale, Florida.
Awesome. Well, we're welcoming you back to Florida.
Yes.
Super excited about that. And obviously welcome you to the podcast. So your specialty is a very small niche, if you will, right?
Yes.
And obviously you have extra training in it, like you mentioned. And I think it's a super important topic and often a sensitive one as well. So when we discuss infertility, not everybody maybe understands what the definition is. So
Sure.
Can you define that for us?
Sure. And I actually love this question because there's some general guidelines that are helpful, not only for patients, but also for providers. So if a patient is under 35, but she's been having unprotected intercourse for over a year, it's time for her to see a specialist, at the very least to undergo a fertility evaluation. Sometimes I'll get patients who are in their mid-20s, 24, 25, they've been married for a couple years, but because they're so young, there's this tendency, oh, just keep trying, it'll happen. Oh, don't worry about it. But really, if they're under 35, regardless of age, and they've been trying for over a year, it's time for an evaluation. Now, if a woman is over the age of 35, we know that that biological clock is real, it does tick, and we do begin to see a decline in fertility after age 35. Now, between 35 and 40, that decline is slow, it's progressive, continual, and then after 40, it becomes much more acute and dramatic. But for those women who are over 35, if they've been having unprotected intercourse for at least 6 months, then they need to see somebody as well. So it's either 6 months or 12 months, depending on age. Now, I do add some other indications there. So for example, if your periods are not predictable, so you have no way of timing intercourse, you don't know when you're ovulating, please don't wait a year or 2. Definitely see somebody sooner. If your periods are extremely painful or very heavy, basically you're calling out of work or you're having to miss school because your periods are so abnormal, definitely you don't want to wait as long either. So one of the first things, and I think we're going to talk about this in a minute, is kind of what's normal, what's not normal. So in the setting of quote unquote normal, reliable, predictable monthly cycles, then the age and the time is taken into consideration. But outside of that, you definitely want to make sure you're being evaluated sooner than 6 and 12 months.
Okay. So basically, in summary, if you're under 35, 1 year of unprotected sex and actually trying, it would be go see someone, something could be going on, right? And then if you're over 35, don't wait so long, maybe because, the cycle is, like you said, the clock is ticking, that they would recommend seeing someone earlier than that, like 6 months rather than wait a whole year. Okay.
Correct.
And then obviously there are other special cases. Okay. So who's at risk for having infertility?
Oh, that's a great question. I think we're continuing to learn that answer. Certainly, I would say number one, maternal age trumps all. And so the older women are always going to have that risk factor for infertility because of the decline in the number of eggs that we're working with and the quality of the eggs that we're working with. But we also know that women who have fibroids, women who have menstrual issues, so if they're having irregular cycles, they can also have risk for infertility. If they have very painful periods, it could be endometriosis or adenomyosis, could also be scar tissue from previous infection or surgeries. The scar tissue could potentially block tubes. So all of these different scenarios are going to put women at risk for infertility. I think one thing I want to highlight, though, is that it's not just about the women, right? So when you break down the causes of infertility, we see that about 30% of the time it's a female factor. About 30% of the time it's a male factor if there's a male partner involved. And then 20% of the time it's something in both partners. So when I talk about a fertility evaluation, absolutely, it always includes a male semen analysis if there's a male partner involved.
So that didn't add up to 100. What's the other?
Yes. Oh, you caught me. So you're right. So 30% female, 30% male, 60%, 20%. And these are rough estimates, right?
Yeah.
But 20% both. So 20% of the time we have what's called unexplained infertility. And that's 1 in 5 couples that I see. And I actually don't like that term. It's not actually unexplained. To me, it's undiagnosed infertility. And what it's really telling me is that the testing available today is not finding whatever it is that's going on with that couple.
Got it. So one thing we mentioned, and just because our listeners may not know, why do we say the clock is ticking? You mentioned the egg. So can you speak toward that?
Yeah. So what we know is there is a decline in, and this was actually, the data was looked at in indigenous populations that don't use contraception. And so they followed the pregnancies of those general populations. And what they found is that the pregnancy rate began to decline after a certain age. And that decline was much more acute after age 40. Now, fast forward, we have all this additional research. And what we see is that there's a decline in the number of eggs that we're working with. So egg quantity, also known as ovarian reserve, and that's actually something we can check by blood work and by ultrasound, the number of eggs that are remaining. And we begin to see that decline after age 35. Certainly, there's a much more rapid decline after age 40. But it's not just the number. We also see that the health of the egg begins to decline. So the quality of the DNA, the likelihood of generating a normal embryo, and I don't want to get too sciencey here, but it really goes down at the molecular level. We begin to see changes that are going to impact the likelihood of a woman conceiving. So, the example I always give is I have a patient, she's 35, she has 2 children, she's trying for a third. Likelihood of pregnancy in that woman is going to be roughly 20% per month. And that is her spontaneous pregnancy rate, no history of infertility. That same woman by age 40 has a 5% pregnancy rate. So that decline, while still being considered fertile, is related to her age and the impact to the egg quantity and quality. We also talk about miscarriage risk. So that same patient at 35 has a risk of miscarriage about 10 to 12%. That same woman at age 40, her risk for miscarriage is closer to 40%. Again, the impact to the quality or health of the DNA of that egg.
So in general terms, though, a woman is born with all the eggs that they're going to have, right? So the quantity obviously is decreasing over time. And clearly from what you've stated, the quality is also decreasing over time.
Absolutely. Yeah. Now, there's a lot of bench research happening right now to try and change that truth. But until now, current science, we are not able to reverse ovarian aging. And so basically, I think of it like a funnel where we have our healthiest. And if you think of, and this is maybe not the best analogy, but if you think of a basket of fries, at the top, you have the most seasoned, the warmest, they're fresh out of the oven, they're the crispiest, et cetera. And then as you get towards the bottom of that basket, they tend to be colder, maybe they're a little stale, et cetera. And so that's really the analogy or the visual that I think of when I'm thinking of our egg supply. We're born with everything we're going to have, and we lose those eggs progressively and continually as we age.
Okay. So you mentioned some risk factors with I think with actual anatomy of the uterus and everything. What about hormonal risk factors of people who could be at risk for infertility?
That's a great question. So when a patient is going to be undergoing a fertility evaluation, we kind of break it down into a few different aspects. So the first thing we're going to ask is about lifestyle risk factors. And this is where your role becomes much more important, because now we're talking about, okay, how's your nutrition? How's your weight? Are you a smoker? What's your caffeine intake? What's your alcohol intake? We're a very alcohol socialized society. What does that look like? How's your sleep? We have a fellow colleague who says that sleep is the forgotten pillar of health. How's your stress, et cetera? So those are all the lifestyle components that can be potentially impacting fertility. And we know, for example, night shift workers in healthcare, that's very common. Night shift workers, we know that they are at increased risk for menstrual irregularity and infertility. So there are certain professions that will be at higher risk. Now, the second piece is going to be structural. What is the anatomy of the uterus? What is the anatomy of the fallopian tubes? Are they open or not? And then hormonal, to your point, is, okay, if we check a patient's hormones, what exactly are we looking for? What does that mean to check hormones? And so really, we're trying, when we do a fertility evaluation and we do blood work, we're really looking at two types of things. So one is going to be kind of pre-pregnancy stuff, like a blood type, varicella, rubella. Many fertility specialists will also check your thyroid, because if that's abnormal, that may play a role. And then we're looking at the reproductive hormones. And there's a few of them: FSH, LH, estrogen. AMH is probably the one that the buzzword that people are trending and hearing about. AMH stands for anti-Mullerian hormone. Really, those reproductive hormones are looking at that ovarian activity that we were talking about earlier. So they're really trying to give us a reflection or an assessment of what that ovarian reserve or egg quantity is.
Got it. Okay. That definitely helps with all the risk factors. What about STD history?
Ooh, great question. So, as part of the annual visit, most general OBGYNs will be checking for STDs. In married patients, when I was practicing general OBGYN, I still did it anyway. So once a year, if they were coming in for their annual, they were getting a full STI check, because you just never know. Anything can happen, and they're more common than people think. For patients who have a known STI history, so sexually transmitted infection, basically we know that the main risk is to the fallopian tubes. The fallopian tubes are extremely, extremely delicate tissue. And once they've been injured, there's no way to really reverse or correct that injury. And so a previous sexually transmitted infection can damage those fallopian tubes, block them, in which case you prevent communication between the egg and sperm. And so fertilization and pregnancy cannot happen.
And we're usually talking about gonorrhea or chlamydia, right?
Gonorrhea and chlamydia are the two most common, yes.
Okay. So I have to ask about the male thing. I don't know if this is fact or fiction, but for that 30% male infertility, does saunas or anything like that decrease the fertility of the male?
Yeah, that's a great question. So we know that the testicles are outside the body for a reason. So extracorporeal for a reason, because they tend to need a lower temperature to be able to function properly. So we do see that in men who now, if you use it once a year, not a big deal, right? But for men who use it regularly, I have guys who are athletes, they work out 4 or 5 times a week. And so they want to do like a very hot jacuzzi or a sauna after their workouts. There's also certain professions, my firefighters, my long distance truck drivers, who are sitting and have the heat from the engine that they're sitting on. So there's a lot of different exposures, but the short answer there is regular, prolonged exposure to heat can absolutely be a risk factor for male infertility.
And how about bicycle riding for the men?
Ooh, that's a great question. So I think it's going to fall into that same category of risk exposure. If you're doing it once a week, probably not that bad. If you're doing it every day or in a very regular fashion, and you're going long distances and you're having that seat, and there's also that pressure trauma as well, right? That could potentially be a risk factor. So I would include it in that gamut. Yeah.
Are there any other male associated risk factors?
So absolutely. So we talked about the lifestyle ones earlier. All of those, the same apply for men. Okay. So that's number one. Number two is that in general, and I'm not discriminating, but generally speaking, women tend to see a doctor at least once a year. And I think we've been kind of educated in that way because of our PAPs. Men, I have many men who do not see a doctor, 3, 5, 10 years. And so general health conditions, I've actually diagnosed from an abnormal semen analysis, I've diagnosed poorly controlled diabetes or other metabolic diseases like high blood pressure, high cholesterol, et cetera. So I always tell patients reproductive health is a reflection of your general health. If your general health is bad, there is going to be a play on your reproductive health. The other one that I think is not talked about enough is the use of external testosterones, steroids, and all of those things that men are using, typically not discussed with their, well, I shouldn't say typically, many times not discussed with their partner. And we don't find it out until we do a semen analysis. And the way I think about all of those supplements is like a male birth control. If you are giving your body external testosterone, the body is saying, okay, cool, I don't need to make testosterone. And so testicular production of testosterone drops dramatically. The problem with that is that high levels of testicular testosterone are necessary for sperm production to occur. So if testosterone production drops in the testicle, guess what? Sperm production is going to follow. Now, most of the time that is reversible. We find it, they come off the testosterone, they get on a different medication. And with time, 3, 6, 9 months, sometimes a year, we do see that to be reversible, but not always. I've had a couple guys where unfortunately that was an irreversible change. The other one I think that we need to talk about and is not talked about enough is bariatric surgery. So that's going to be something like the gastric sleeve or gastric bypass. And if there's a man who is significantly obese and is going to be undergoing bariatric surgery, occasionally we have seen complete cessation of sperm production afterwards. And so generally the recommendation is if there is an opportunity to freeze sperm, just in case. Not always going to happen. And if it doesn't, that's great. That's fine. But at least you have that backup option.
So what would you recommend to a male who has low testosterone yet wants to become a parent? And
Sure.
What do you do? Do you start the testosterone or do you not?
That's a great question. So I will just say I defer to my urology colleagues for like the expert information on this, but male fertility does fall within my scope. I'm tested on it for my board, so I have to know about it. And generally speaking, you know, if we have an abnormal semen analysis, typically we do 2 of them for confirmation. The next step is to kind of do a little bit of a deeper dive. And so those same reproductive hormones we were checking in the female partner are typically looked at in the male partner. And if low testosterone is found, then there sometimes can be medications given, not external testosterone, but there can be medications given to the male partner that can potentially increase those levels. So one that many people might know, Clomid, we use it for women and for fertility in women, can also be used in the male partner. It's used differently. The regimens are totally different, but it's another medication that can be used. Anastrozole is another medication. HCG injections is another medication. So again, this is not typically managed by a fertility specialist. It's typically managed by a reproductive urologist, but there are options. Now, again, depending on the diagnosis, right? Because we want to make sure we're treating appropriately. The other thing to take into consideration is that anytime you're going to treat the male partner, typically we wait 3 months, because from sperm production in the testicle to ejaculation, it's roughly a 3-month process or a 3-month transport. And so for us to see changes from the medication is a minimum of 3 months. And so for any medication we're using, we're typically not repeating another semen analysis for at least 3 months. And so this may become relevant. Let's say the woman is older, she has her own diagnoses going on, and that 3-month wait may not be reasonable. And we may have to forego that and do something else. So it's always looking at the parts and the whole together and then coming up with the best treatment plan for that couple.
Perfect. Why don't we switch back to the woman? Because I think we were going to discuss, like with the periods, what's normal, what's not, where do they go from there?
Yeah. So I think we're doing a little bit better in this department, but I think we still have a long way to go. I mean, I have patients, I don't want to say every day, but certainly every week, who have debilitating, painful periods and who are told that's just part of being a woman, tough it out, not a big deal. And we now know that that is not accurate, right? So my message to any woman listening is that if your pain with your periods is so significant that you are planning your life around it. I had one patient who would plan her vacations around when she was going to get her period because she was like out of commission during those days. If it is impacting your quality of life, if you're having to miss work or school, If it's not significantly improved with over-the-counter medications like Tylenol, ibuprofen, those types of things, then you definitely want to be talking to either your OBGYN or a specialist about it. And then I think the other big thing is cycle regularity. Especially in my younger patients, sometimes getting 3 or 4 cycles a year, they're like, wow, this is great. I don't have to worry about it. But my message to any woman listening is that if you are of reproductive age, so you've had your first period and you're not menopausal yet, and you are otherwise healthy with no significant medical issues, and you are not on any form of hormone suppression, like an IUD or birth control or anything like that, then you should be getting a regular monthly period. And if that is not happening, then you are not ovulating, at least not in any sort of regular or predictable fashion. So a regular period is defined as a cycle day 1 is first day of full flow. So from cycle day 1 to cycle day 1, roughly 28 days plus minus a week. And then the other thing I would say to that is that if 1 month it's 21 days, the next month it's 35, the next month it's 23, the next month it's 34. Yes, you fall within that normal range, but they're not predictable and they're not reliable. And so I would still consider that, hey, maybe you should talk to somebody. But having a monthly predictable period is super important. And if that's not happening, then an evaluation needs to be done. General health concerns, things like abnormal thyroid, another hormone, prolactin, which is the hormone of breastfeeding, can be elevated in women and men too, but less so. We talk about PCOS a lot. PCOS stands for polycystic ovarian syndrome. And despite the name, it is not cysts on the ovaries. It is an egg excess disease and can be a cause for irregular cycles. The other thing is premature ovarian failure, or basically like an early menopause. That's when the egg supply has been depleted at an early age. And so therefore the woman enters menopause under the age of 40. And a lot of times young women with irregular cycles are deemed PCOS without really much evaluation. You want to make sure that a full hormonal panel has been done, an ultrasound has been done, et cetera, just to make sure that we're looking at everything and we're coming up with the right label or the right diagnosis. So number 1, pain with periods. Number 2, cycle regularity, or sort of having a predictable cycle every month. Number 3, menstrual flow. And the NIH actually came up with a nice graph because they were talking about it in volume, like a 2-liter soda, but most women are using pads and tampons, so you couldn't really correlate it or quantify it. But they now have a point system, and it's based on the number of saturated pads or the number of saturated tampons, and then whether or not you have heavy clots with it. It's a scoring system. If it's over 100 points, then your flow is considered heavy. So that would be sort of a general parameter to follow. So again, period pain, period regularity, and then period flow, I think are the 3 things that I would talk about. And the 4th I'll just throw in there is timing intercourse. I have a lot of patients who are like, well, I was told to have sex every other day, like all month, or I was told to have sex a couple times a day around 2 weeks after my period or whatnot. And so it can be really tough to know whether you're timing intercourse correctly or not. And that's where knowing your cycle regularity and knowing those days can be so important. So again, that cycle day 1, first day of full flow, to your next cycle day 1, first day of full flow. So if you have a 28-day cycle, ovulation is going to be occurring right around day 14. And so we typically will have you start testing for ovulation around day 10 or 12. You'll get a couple days of negatives before it turns positive. So I know I went a little bit long there, but hopefully those are some good pointers for your audience.
No, definitely. You went over all the things that would be normal, abnormal, and that's perfect. And then the ovulation timing is obviously super important and key because that's when the eggs release so that they can meet the sperm and become fertile. So how do they know they're ovulating? You mentioned testing. So can you describe that?
That's a great question. So number 1, everybody these days has a menstrual tracker, and that's usually an app that's following your cycle day 1 to your next cycle day 1. My only caveat there in the era of Roe v. Wade being overturned is some women don't want that because of information collection. And so it's just as easy to grab a calendar and do it that way. And you just want to mark your cycle day 1 to your next cycle day 1. So you can establish over a 2 to 3 month time frame what your cycle length is. The next thing is that we know that post-ovulation, it's a fixed time of approximately 2 weeks. So once you've ovulated, your period's going to come roughly about 2 weeks from then. So whatever your cycle length is, if you subtract 14 days, then you're going to get when you're ovulating. So for example, if you have a long cycle, you have 33-day cycles. If you subtract 14 to that, then you're going to be ovulating roughly around day 19, I think. So
I didn't do
just
the math.
trying, yeah, day 9, I know, doing the math. So 33 minus 19, minus 14 is 19. But if you have a consistent 23-day cycle, so 23 minus 14, you're going to be ovulating closer to day 9. And so having a 2 to 3 month time frame of cycle length, and whatever that cycle length is, subtracting the number 14 because it's 2 weeks between ovulation and a period. And so that'll allow you to know when to start testing. I like the ovulation predictor kits. They're found in any pharmacy or big box store in the feminine hygiene aisle. They're in the same area as the pregnancy test. It's just looking for ovulation instead of pregnancy. Mm-hmm. And it's become really a whole industry, very commercialized. You have like the super fancy advanced digital, et cetera, high and peak fertility and all this fancy stuff. Really, like when I was trying, I used the Walmart brand that worked just fine for me. So I don't partake in any particular brand. It's really what's going to work for you and be reliable. And so you want to understand your cycle length to know more or less when you should be ovulating, and then start testing a couple days before. You should get a negative those first 2 or 3 days until eventually it turns positive. Now, the end point to this, or the added bullet point that I'll say, let's say you do this for 2 to 3 months and it's not reliable. You can't figure out when to time intercourse. Please don't continue trying. Just go see a specialist. Like, please go see your OBGYN or a fertility specialist, because number one, sex becomes very mechanical, very medicalized. And so it really takes a toll on the relationship and can be extremely frustrating, disappointing, and anger generating when you're not able to predict ovulation or time intercourse properly. And so for women where the OPK or ovulation predictor kit works, it's great because it allows you to sort of confine the quote unquote baby making sex to those 2 days a month. And then the rest of the time can be for connection and intimacy. And for about 20% of women, roughly, the OPK is not going to work, and they're not going to be able to time intercourse appropriately. And they're going to need the assistance of monitoring either by ultrasound or other measures with their OBGYN or their fertility specialist.
Do you recommend they do like the oral temperature or measuring like vaginal discharge or anything like that?
So I personally don't. Back when I was I think it was a first-year fellow, cervical mucus was officially removed as part of the standard fertility evaluation. There was just so much variability woman to woman. There's so much variability cycle to cycle. The basal body temperature, for those who want to do it, I have nothing against it. It's just so tedious and so much work that I'm not a huge fan. But again, there's nothing against it. It works well. I will say with the basal body temperature and the cervical mucus, you're typically finding ovulation after it's already happened. And so the basal body temperature is great for looking at that trend that I was talking about earlier of cycle length to be able to predict ovulation.
Got it. Yeah. And we have such good testing methods. And if the ovulation kits are going to work for you, like they work pretty well. The only thing would be a cost, because the other 2 things I mentioned are free.
Yes.
Well, unless you don't have a thermometer. All right. So you already kind of mentioned this, when to see the specialist, but what other reasons can you think of when you should actually see the specialist?
Yeah. So I would say under 35, trying for over a year, over 35, trying for over 6 months, abnormal or irregular cycles, extremely painful periods. But then there's a whole bucket of known risk factors for infertility. My mom struggled with building her family. It took her a long time, or she had a hard time. My husband has a history of a motor vehicle accident, and he had surgery in his groin region at that time. I had a ruptured appendix as a child and had to have multiple surgeries to clean all the infection up after that. There's a host of risk factors that could potentially contribute to infertility. And so if there's something significant in your medical history, it may be worth seeing a specialist sooner. And the last bullet point I always like to insert, the asterisk at the end, is if you're anxious and don't meet any of these criteria, you can still have a consultation with a fertility specialist, because sometimes all it takes is talking to someone, going through all of this and saying, oh, okay, I'm reassured. Or sometimes the talking is not enough. you want to do testing, the testing comes back okay, and then you're reassured, or the testing doesn't come back okay, and then you're sort of, changing or shifting that conversation. So I don't want to limit or sort of narrow. The other thing a lot of patients don't know is that most times you actually don't need a referral to see a fertility specialist. It depends on your insurance plan. Of course, you want to call and find that out. But for most patients, they can just call and book an appointment on their own. And so, waiting for your PCP or your OBGYN is not always necessary if you do have those additional questions.
That's definitely good to know. And I also was going to comment on that you said with the anxiety, because part of that is part of the problem. And once they get reassured or stop going crazy trying, then sometimes they have success. So I think what you said is kind of worthwhile to bring it up sooner and be reassured after testing or anything like that than waiting forever. So I think that's a really good point. So what happens when they come to someone like you, a super specialist, right? And how do you work them up, or what do you do?
Yeah. So the first thing is going to be a deep dive of the history. And if there's a partner involved, male or female, their partner will also be asked questions. And that's just really the doctors just trying to get an assessment of what's going on. What are the potential risk factors? What kind of case are we looking at here? Is there any additional testing besides the baseline that I should be doing? So that deep dive into the history is really the big one. Some specialists do a physical exam, and some specialists also do a vaginal ultrasound. So if you are seeing a fertility specialist, I do encourage you to just ask that question. What should I expect when I come? Is it just talking, or is there going to be an exam and or an ultrasound as well? Because sometimes that can catch patients off guard. If you're meeting with me, it will be a consultation only, where we do a deep dive of your history. We talk about any risk factors, and then we talk about testing in the next phase. So testing typically has 5 components to it. Number 1 is going to be the blood work that I mentioned earlier. So looking at the pre-pregnancy stuff and your reproductive hormones, a vaginal ultrasound. That vaginal ultrasound is typically done during your menses. Some sort of assessment of your fallopian tubes. The most common test for that is called the HSG, or hysterosalpingogram. It's an X-ray study. There's another study, we call it fondly the bubble test. So it's a water ultrasound in the office with bubbles that assess the fallopian tubes. That's less common, but also possible. The 4th would be a semen analysis if there's a male partner involved. And then lastly, genetic screening. And genetic screening, the type of testing that we do may vary depending on the individual case, but the screening that we're generally looking for most patients is carrier diseases. And what I mean by that is that they themselves do not have any sort of mutation or disease, but they are a carrier for that disease. So if their partner or if the sperm source is also a carrier for the disease, then their offspring has a chance to be impacted if they inherit both of the abnormal genes.
Got it. You said 5 things, right? That's a pretty thorough workup, right?
It's a very thorough workup. There's a lot of poking and prodding. I generally say to get all of it done, you're looking at probably 4 to 6 weeks. And that's just the fertility testing, because I'm also going to be talking to you about what nutrition changes need to happen, what supplements do we need to be starting, what other integrative practices like acupuncture, et cetera. So there's a whole lot that goes into that consultation. Number 1, having a rapport with the doctor that you're seeing, I think, is super important in the fertility, in all of medicine, but in fertility specifically, it's just such an intimate, vulnerable chapter in a patient's medical life that you really want to make sure you have good communication with your doc. And then the second one is having a second person or a second set of ears for the consultation, because there's so much information coming at you at once. It can be very overwhelming. Many patients are already nervous to see a fertility specialist. Most of them never thought they would actually have to get to that point. And so that first visit can be a lot. So having a second person there, even taking notes, that's all very reasonable and expected. And most clinics will kind of handhold you or guide you through that testing phase, but it takes about 4 to 6 weeks to get all of it completed.
And then I don't know if we want to go into that, but like what would happen next, I guess, after all the tests?
So I'll just say treatment in general. I like to break it down into 3 things. And we mentioned a little bit of this, but 1 is lifestyle optimization. So that's part of the treatment, right? Are you working with a dietitian? Are you working with a trainer? Is there anything else you need to clean up? How much is your job? And we mentioned night shift workers at the beginning of the podcast. Like, do we need to revisit that conversation, et cetera? Number 2, supplements. supplements. So depending on the workup, there may be additional supplements added to your prenatal regimen. And then number 3 is the fertility treatment. And the fertility treatment, generally speaking, I tell patients, look, the female partner is going to be receiving fertility medication, either oral, injectable, or a combination of both, but she's going to be receiving fertility meds. And then that can be combined either with timed intercourse, with IUI, which is intrauterine insemination, where we put the sperm inside the uterus, very much like a pap smear visit, or with IVF, which is in vitro fertilization or embryo creation. And so depending on the case and depending on the testing, they're going to fall into one of those 3 categories, and we'll do a deep dive into what that particular case needs.
Awesome. You gave us so much information here. Is there anything that we left out?
I know.
I'm sure there's plenty of it.
I think there's kind of 2 main messages. Well, maybe a couple. I know I'm a talker, but number 1, I would say, is that just because you're seeing a fertility specialist does not mean you have to do IVF. And I think that's where people's heads go. I think we are so much more than that. And we really are invested in trying to understand the root cause of the infertility, if there is one, and then trying to correct that root cause and increase pregnancy rates. So that's number 1. So fertility specialist does not always equal IVF. Number 2 is being a self-advocate and not waiting. I've never heard somebody regret, oh, I froze my eggs too soon, or, oh, I went into treatment too soon. I've only heard the opposite. I've only heard, I wish I would have known. I wish it would have taken action a couple of years ago. I wish someone would have told me, etc. So really being a self-advocate and not waiting or not hesitating to get those questions answered. And then the third one is just understanding that biological clock. As much as we wish it wasn't true, especially in today's society with so many women getting advanced degrees and being career focused, family building, a lot of times, I know it happened to me, it gets put on the back burner. And fertility preservation is an option that we didn't have as recently as 10 years ago. ASRM only removed the label of experimental for egg freezing in 2012. So it wasn't that long ago that this wasn't even an option for women. So just understanding your body and understanding what your options are, that's the mainstay of why I'm here today, why I'm on social, why I'm on all these different platforms.
Even as a provider, I'm guilty. I do associate it with IVF, and I don't know why, but yeah, I think that these are really important concepts that you're sharing with everybody. So it's
thank
awesome.
you.
So where can everybody find you? You mentioned your social. So what is
it? Thank you so much for that question. So I'm probably most active on Instagram, but I'm on Instagram, I'm on Facebook, YouTube. Haven't made it to TikTok, not sure if I will. And I also have a website, and across all channels, I kept it the same. So Dr. Carolina Sueldo, it's very easy. If you Google me, most of those platforms will pop up.
Awesome. Well, we'll include that in the show notes. Okay. Thank you so much for coming on today. And
thank you, Dr.
Excellent
Reller.
Discussion. So
yes.
awesome.
Thank you so much for having me. This was great.